Good afternoon, everyone, and thank you for being here. I'm Penny Jefferson, and we're going to be talking about preventing denials at the front line. We're going to spend the next hour focused on one central idea. Denials are not a billing problem. They're a documentation problem, and that problem starts at the moment of admission, not at the back end of the revenue cycle. So by the end of the session, I want you to leave with a different lens on what it means to document at the point of the decision. And I'm going to provide some concrete tools you can take back to your teams at your institutions. But before we get started, I want to give you a little context for the perspective I'm bringing in today. I lead the Clinical Documentation Integrity Program at UC Davis Health in Sacramento, California. It's a 650 plus bed level 1 trauma academic medical center, and my work spans inpatient and outpatient CDI, coding, utilization review, physician advisor alignment, denial management, and revenue cycle strategy. So I sit in the middle of pretty much all of the revenue cycle. That I also participate in looking at payer behavior, quality reporting, compliance risk, and financial impact in my everyday work. What I'm sharing with you today, it's not theoretical. It comes from the work we're doing in real time, the denial patterns we're seeing, and the operational pressure hospitals are facing as payers review the record earlier and more aggressively. I want to start with why this matters so much. We all know that denials aren't new. Hospitals have been dealing with them for years, but our big change is the speed, the pressure, and the level of scrutiny that our records are being reviewed. Denials are continuing to increase across the payer landscape, especially with commercial payers and Medicare Advantage. And while every payer may deny for slightly different reasons, the denials that create the most disruptions are often tied to clinical issues, medical necessity, prior authorization, pre-certification, level of care, and whether the documentation supports the care being delivered. And here's the part we really need to pay attention to. Payers are not waiting until the end of the stay anymore. They're reviewing the record early, sometimes within hours of admission. And that's completely new for us. They are looking at what is documented at the point in time and making coverage decisions based on what they see. So if the why inpatient, the severity, the risk, the failed outpatient treatment, the monitoring needs, or the expected course of care are not clearly documented in the record early, we may already be behind. So most organizations are not losing these cases because the care was inappropriate. They're losing them because the documentation did not make the clinical decision defensible early enough. The physician may have had the right concern, the team may have delivered the right care, the patient may have absolutely needed to be in the hospital. But if that reasoning isn't visible early in the record, the payer they can't infer it. We have nothing to defend the record with. That is the challenge we're dealing with now. We're not just documenting what happened, we're documenting why the level of care was necessary at the time the decision was made. So the key to this is the window to prevent a denial is shrinking dramatically. Documentation quality at admission is now the primary defense.